Pranamam.
Sure.
Thank you.
Okay. Very good evening to all. Today we are having another session of the Journal Club developed by IAP Thiruvananthapuram. Today we have interesting paper presenting from the PRS hospital. We have Dr. Ramankutty sir, Dr. Patnavan sir, and mentor Dr.Amritha, Dr.Aswathi, and Dr.Lasima in the presentation team. And I would like to request Dr. Sridhar Kumar to start the session. Over to Dr.
Anju had already given an introduction, and welcome to IAP Trivandrum platform for the Journal Club. And I will congratulate the coordinators, Dr. Anju Kanmani and Patnavan sir and Ramankutty sir for continued effort and cooperation with the IAP Trivandrum for this Journal Clubs. And I also congratulate the organizers to take this particular topic, the hot topic doing the rounds, the rabies post-exposure prophylaxis thing. So we are very happy to learn that, and we are very eager to look for the outcome of this study also. And we have Dr. Kalpana Madam also joined. So if Kalpana Madam is there, can have a few words also. Kalpana Madam.
So all the best for the session. It's a very nice session and interesting on rabies vaccine and immunoglobulins and monoclonal antibodies, and we will hear from this session.
Okay, I would like to request Dr. Patnavan sir to give the intro and carry on the session. Or to Dr. Patnavan sir. Thank you, Dr. Sridhar sir.
Oh, I'm sorry, I shared the. Can you see my screen? I don't know. I'm not seeing it. What happened?
Yes, so we can see. Screen is visible, sir. Only thing is make it full screen.
Yeah, but I am not. 1 minute. Share. I am not seeing it. I should also see it, isn't it? Let me see. Okay, now can you see it?
Yes, sir. Yes, sir.
Okay. Now, normally I don't interfere in the presentation, but today it's a very important topic, and I picked up this article from Lancet. It's not easy to get a full PDF, and I think it has come in the last few months. I don't know the date. I don't remember the date. Now, I am just trying to put the article in the proper context. Now, where do we see? There are a few general practitioners as well as general pediatricians. We say we take life and death decisions. Most of the time, the children survive on their own, or they survive in spite of a treatment. But here, this decision is something where whether you give rabies vaccine, whether you give the anti-sera or the monoclonal antibody, and all this becomes a life and death issue actually for the patients. And you would have noted that already about 13 or 14 deaths have occurred in this year in Kerala. Is not acceptable, far in excess. Therefore, there are various questions. Now, where do you get the information? You get various information from the WHO, the Purple Book, which is published in 2022. National guidelines are there in 2019, and there is a general aspects in 2022 rabies. Therefore, when there is a national guidelines, it becomes binding for the doctors to follow to a certain extent. And then Indian Academy of Pediatrics has published its recommendation independently as well as in the Purple Book, and then there is CDC and up-to-date record. Therefore, I just want to point out certain things here about monoclonal antibody. Now, this is the national guidelines for rabies prophylaxis, 2019. There's no mention of monoclonal antibody for rabies prophylaxis. This is something you should understand. The 2019, therefore you might think that it is an old one, maybe they updated it. 2022, again, general aspect. The National Ministry of Health and Family Affairs, passive immunization. Let me see if I can bring the pointer. I'm not point. I'm sure I think you can see the pointer, is it not? They are mentioning only equine rabies immunoglobulin and human rabies immunoglobulin. They are not talking of monoclonal antibody. Looks very surprising. Okay. Now, sorry. It not going. Not shifting, I think. It is not shift. Yeah. Therefore, they didn't mention it in that. And what is important is that advances in monoclonal antibodies and rabies vaccine, Rabishield, which is produced in by the Serum Institute, the first one to produce a monoclonal antibody in the world. There has been human vaccine immunotherapy. It has come about in international journals also. The 1767 is what is the monoclonal antibody produced by Serum Institute, was the most wide, broadly neutralizing monoclonal antibody. 92% of the 25 rabies virus isolated tests. Serum Institute rabies monoclonal antibody showed a higher neutralizing effect than ERIG. ERIG means equine rabies immunoglobulin. That's what is given in the government sector. Or human rabies immunoglobulin, rarely given because it's very, very costly and did not interfere with the immune response of the rabies vaccine in the standard EPP regime. We also have, and nowadays we have a twin drab produced by Cadila, is a combination of two murine monoclonal antibodies. They bind to two different epitopes on the G protein expressed on the surface of rabies vaccine. The two monoclonal antibodies bind and neutralize both rabies and rabies-like viruses, preventing the infection into a neighboring cells. The cocktail of antibodies was also found to neutralize rabies strains isolated from dog, canine, human, bovine sources, southern parts of India. Now this is what it is. The national guidelines is silent. The ACVIP, that is the Indian Academy of Pediatrics Committee on it, strongly recommends the use of monoclonal rabies and antibody over RIG in the management of category 3 bites. Remember, this is a very strong statement. Therefore, since we are giving monoclonal antibody in the private sector, we have the support of the Indian Academy of Pediatrics in this. But still, there can be a medico-legal angle, because when the national guidelines does not even talk about it, can we give monoclonal rabies antibody? Anyway, because of that. And one thing I want you to note, in 2018 WHO, okay, WHO, it is not that it is an Indian product, monoclonal antibody. The Indian national government is keeping quiet on it. WHO in 2018, a single monoclonal antibody product against rabies, licensed in India in 2017, has been demonstrated to be safe and effective in clinical trials. Therefore, it has the approval of the WHO. That's what is important in it. Now, the ACVIP committee endorses the use of rabies monoclonal antibody as an alternative, and it shows the WHO position paper rabies has also suggested encouragement of use of this product if available instead of RIG. Therefore, if it is available, you should use it. Possibly greater effectiveness. You include easy availability, standard product, greater effectiveness. They go to the extent of that. Therefore, the recommendation for monoclonal antibodies, ACP strongly recommends the use of monoclonal rabies over RIG in the management of category 3. This is given in the purple book also. Therefore, this is what, there is a dichotomy of opinion. This is not something very simple. When the national guidelines is saying, normally it is something binding. When they don't talk of monoclonal antibody, when in the private sector you're giving monoclonal antibody, you are in a little of trouble. Now, let me tell you why exactly. They don't say any reason. They don't even discuss it, national guidelines. But the fact they say is it doesn't cover all the epitopes of the rabies in rabies vaccine. Therefore, it doesn't cover all the epitopes. Therefore, it should not be used. A broader one should be used. They are not given any references, but that's what is said. Now, that is it. I will close the presentation here. Therefore, the sum total is we have a monoclonal antibody which is produced in India for the first time, internationally acknowledged. Even in Lancet has written about it. WHO has accepted. The Indian government, the Indian guidelines don't talk about it. Therefore, there is some problem in it. The government sector gives equine. The IAP says superior one is monoclonal antibody, but when we go for a meeting, we hear that it doesn't cover all the epitopes. No literature is given, but that's the reason why. Therefore, this particular article, therefore, is a very important one for the practicing pediatricians and this one. I close my presentation.
Dr. Padmanabhan, can I raise just one point?
Yeah.
I don't want to take time off from the presentation,
Yeah.
but since you put it so well, I was thinking, has anybody thought of a legal recourse like?
See, the problem is when you present in the earlier when I go to IAP, when the doctors from the medical college and all present very well, they just keep quiet on monoclonal antibody. Therefore, I again
So that is why I'm saying, because our friend Dr. Babu, I'm sure you know Babu.
yeah.
He's used the court very effectively in getting rulings in favor of doctors. I mean, can we try that? I'm just floating a thought.
Let's listen to this article and see
Yeah,
how.
sure.
Because this is the first article. I mean, you would have read it.
Yeah,
And
yes.
even today, a professor of pediatrics, he told me a few weeks back to me, doctor, it doesn't cover all the epitopes. I mean, I said, can you give me the reference? No, some meeting in national meeting, they are told like that. That's it. Therefore, I called, actually, I wrote this to many people and said, please raise it up with the national government, but the IAP is not interested in doing it. Okay, can we have the presentation?
I think you have done a good thing in raising this issue.
Yeah, because this article came up actually in Lancet. It is not available full. I got it through some way, and I insisted Anju to present this topic. Okay. Okay, Dr. K. Hello. Can we go to the presentation?
Yes, sir.
Who's presenting first? Ashwati?
Yes, sir.
Can you share your screen? Okay. Make it full. I think it's not full screen. Anyway, it's up to you. Ashwati, can you unmute and talk?
Okay, sir.
Okay, present.
So, good evening, everyone.
Yes, continue.
Okay, I'm Dr. Aswathi. I'm the first year PG resident from PRS hospital. And today we are going to discuss about the post-exposure prophylaxis regimen of the rabies monoclonal antibody and vaccine in the category 3 potential exposure patients. So it's a phase 4 open label randomized active control trial conducted across 15 tertiary care hospitals across India.
No, that screen, you're reading something which is not in the screen. Post-exposure, what is showing in the screen is something different. Yeah, read it now. Correct. Go ahead.
Okay, sir. Then in background, Rabies is a lethal zoonotic viral disease with nearly 100% fatal once the symptoms develop. It's a major burden in the low and middle income countries in Asia and Africa, and the post-exposure prophylaxis combining vaccines and the passive immunization, which includes the rabies immunoglobulin and the monoclonal antibody, is highly effective in WHO category 3 exposure, that is transdermal bite or scratch or the mucous membrane in contact with the saliva from the suspected rabid animal. The limitations of the existing rabies immunoglobulins. The human rabies immunoglobulin, HRIG, it is derived from the plasma of vaccinated donors, the limited supply, high cost, and is primarily used in high-income countries. Then equine rabies immunoglobulin, ERIG, it is economical and is common in low and middle-income countries. It's derived from horses, heterologous in origin. It requires sensitivity testing due to the rare allergic risk, and there is a risk of infectious agent transmission also. Due to these limitations, a large proportion of rabies exposed patients in the low and middle income countries never receive the rabies immunoglobulin. Then, what is the rationale for the monoclonal antibody therapy? Available as Rabies Shield. It's a fully human monoclonal antibody targeting the rabies G glycoprotein. It is approved in India in 2016 and available since 2017. Produced using recombinant technology, it allows large-scale production with standardized potency with zero infection risk, and it neutralizes a wide range of rabies isolates and provides animal protection evidence in the hamster models. It is included in the WHO model list of essential medicines since 2021. So, study rationale and objectives, study need, because there is limited large-scale data on the long-term safety and the real-world immunogenicity of the monoclonal antibody with vaccine regimen. And the primary objective of this study is to assess the safety of the rabies monoclonal antibody, particularly the rare serious adverse events. And secondary objectives are to compare the immunogenicity and the efficacy of the rabies monoclonal antibody with vaccine versus ERIG with vaccine, and to evaluate the antibody persistence and the adverse event profile. Research done in context on literature search, the PubMed up to January 2025 identified only 12 clinical trials of rabies monoclonal antibodies, of which 2 previous trials on the rabies monoclonal antibody in the phase 1 and the phase 2 or 3. So there is a clear knowledge gap in the lack of large-scale post-marketing safety data. So the added value of this study, it's the largest ever rabies post-exposure prophylaxis study globally with the sample size of 4,059 and is adhered to WHO 2018 guidelines, that is wound infiltration only, no intramuscular backup doses, with 1-year follow-up evaluating both intramuscular as well as intradermal administration, and it supports the WHO recommendation for the monoclonal antibody in post-exposure prophylaxis instead of rabies immunoglobulin. Study design, it's a phase 4 open label randomized active control study conducted across 15 tertiary care hospitals in India with the registration from the Clinical Trials Registry India and approval from national authorities and the Institutional Ethics Committee after getting informed written consent from the participants. And the duration August 21, 2019 to March 31, 2022 with the follow-up period of 1 year per patient. And the last participant follow-up was completed on April 25, 2023. Participants, the eligibility criteria are age more than or equal to 2 years with WHO category 3 exposure from confirmed or suspected rabid animals, and the exposure within 72 hours with an exception of less than 24 hours for the face, neck, hand, and finger bites. Exclusion criteria, the participants with prior rabies vaccination, severe systemic disorders, and the participants with severe allergic reactions to study products. Randomization and masking. All eligible candidates were randomly assigned into 3:1 ratio, that is monoclonal antibody with vaccine and ERIG with vaccine. Within each group, they further randomized in 1:1 to the intramuscular as well as intradermal vaccine routes. And the randomization method was permuted block design with a block size of 8 using SAS version 9.4 list and implemented via nucleus electronic data capture system. And the list was prepared by an unmasked statistician who was not involved in any study data analysis. And as it's an open label design, the participants and investigators are unblinded, but the laboratory team blinded for the antibody assays. Interventions. which includes passive and active immunization. In passive immunization, the monoclonal antibody Rabi Shield from the Serum Institute of India, Pune, with the dose of 3.33 international unit per kg, and is available as sterile solution of IgG1 monoclonal antibody, and is injected into and around the wounds on day 0. Then ERIG, Ecurap from the Bharat Serums and Vaccines, dose of 40 international unit per kg, is also infiltrated locally around the wounds on day 0. And there is no intramuscular reminder administration as per WHO 2018 guidelines. Active immunization with purified varicella rabies vaccine, RabiVax S, IM schedule and ID schedule. IM SN schedule, 1 ml on day 0, 3, 7, 14, and 28. Then intradermal schedule, updated Thai Red Cross regimen, 0.1 ml on both or each deltoid on day 0, 3, 7, and 28. And the storage and transportation at 2 to 8 degrees Celsius. And all participants were observed for 30 minutes for any acute adverse events. In the follow-up schedule, all participants were follow-up during day 0, 3, 7, 14, 28, 210, and the 365 day, with a telephonic follow-up on day 42 for the safety surveillance. The blood samples from the subset of 200 participants, which were randomly selected from the all study groups, and is conducted on day 0, 14, and 365 for the rabies virus neutralizing antibody test via rapid fluorescent focus inhibition test, which is done at NIMHANS, Bangalore. Outcome measures. The primary outcome is the incidence of treatment-related serious adverse events up to day 365. Then secondary outcome, any serious adverse events up to 365 days, and adverse events to 3 days after the last dose of post-exposure regimen, and the overall survival rate until the end of follow-up, and the immunogenicity, that is geometric mean concentration of the rabies virus neutralizing antibody, and the seroresponse rate more than or equal to 0.5 international unit per liter. And adverse events were classified into mild, moderate, severe according to the discomfort caused and the need of intervention. And the causality is determined by site investigators based on clinical judgment. Comes to analysis part. The sample size and the statistical plan. The trial sample size of primarily depend upon this monoclonal antibody group, that is estimated around 3,000 in the monoclonal antibody with vaccine and 1,000 in the ERIG with vaccine group, and it provides 95% probability of detecting at least one severe adverse events occurring with 1:1,000 frequency, and this unequal allocation is used to allow the generation of additional safety data on the monoclonal antibody compared with ERIG. In the immunogenicity analysis, a total of 168 evaluable participants, that is 126 from the monoclonal antibody group and 42 from the ERIG group, provided 99.9% power to show the non-inferiority, assuming a non-inferiority margin of 0.5 for day 14 and the GMC ratio, and a 5% significance level and a standard deviation of 1.033. Assuming a 15% dropout rate, a total of 200 participants were planned to be enrolled in the immunogenicity cohort, with 150 in the rabies monoclonal antibody group and 50 in the ERIG group. Then intention to treat analysis. It's actually all study participants were who received at least day 0 of the vaccine, either monoclonal antibody or ERIG with vaccine, were analyzed as per the randomized treatment allocation. And safety analysis comprised all participants who received at a minimum the day 0 dose of monoclonal antibody or the ERIG were analyzed as per the actual treatment. Then per protocol analysis, it is defined as all study participants who received the complete post-exposure prophylaxis regimen with compliance to protocol specified visit, and modified per protocol analysis set consisted of participants from the per protocol analysis who had baseline rapid fluorescent focus inhibition test titers below 0.5 international unit per ml, and the intention to treat or per protocol and the modified per protocol populations were used for immunogenicity analysis. The statistical analysis performed with the SAS version 9.4, with quantitative variables like age and weight were summarized in mean and median, and the qualitative variables like sex were summarized as frequencies and percentage. adverse events and serious adverse events. The number and percentage of the patients with the adverse events and the serious adverse events were summarized by system organ class. And the summary statistics like frequency percentage, point estimate, the 95% confidence interval were calculated and related serious adverse events and for the survival rate at days 14, 210 and 365. Geometric mean concentration. GMC. It calculated as the anti-log of arithmetic mean of the log 10 transformed to rabies virus neutralizing antibody titers. This GMC is between the study groups, that is monoclonal antibody with vaccine and ERIG with vaccine, were compared by two sample t-test. And the GMC ratio was calculated as the ratio of GMC of monoclonal antibody with vaccine to GMC of ERIG plus vaccine. Then seroresponse, it was defined as serum rabies virus neutralizing antibody concentration of at least 0.5 international unit per ml and calculated for the seroresponse rate at days 0, 14 and 365 in each treatment group. The difference in the proportion between study groups were compared with the two-sided chi-square or the Fisher-Exact test and interpreted at a 5% significance level. The two-sided 95% confidence interval for the ratio of GMC were constructed with a log normal distribution and non-inferiority was concluded if the lower limit of the two-sided 95% confidence interval for the GMC ratio on day 14 was greater than 0.5. The role of funding source, the sponsor is Serum Institute of India and they were included in study design, data interpretation and the manuscript preparation, but data collection and analysis are conducted independently by the investigators. Results. First, the participant enrollment and allocation. 4,062 participants were assessed for eligibility with 4,059 randomly assigned into 4 treatment groups. 3,994 participants received treatment, of which 2,996 with monoclonal antibody with vaccine and 998 with ERIG with vaccine. Follow-up completion rate at 1 year, that is 90.7%. 3,622 participants. Complaints with all scheduled doses of vaccine was 90.8% with the intramuscular regimen and 94.1% in intradermal regimen. In detail, among the 4,062 patients, they are assessed for eligibility. 3 were ineligible, 1 due to investigators' decision and 1 with the previous history of rabies vaccination, of which the 4,059 were enrolled and randomized, of which the 65 was not treated because 60 have positive ERIG hypersensitivity test and 4 withdraw the consent, 1 have history of HIV. So finally, 3,994 participants were treated and vaccinated. And they were randomized into 3:1. For 2,996 received monoclonal antibody and 998 received ERIG. And they further subcategorized into 1:1 randomization. That is 1,100 received monoclonal antibody with intramuscular vaccine and 1,496 received monoclonal antibody with intradermal vaccine, and the same pattern in the ERIG group also. Total 3,994 were treated and vaccinated, but the treatment completed by only 3,622 participants. In this chart, the safety analysis set comprised only 1,500 participants, and the 1,500 participants were included in the intention to treat analysis in the first group, and 55 included in the modified protocol set. The baseline characteristics of the both groups in majority are male, that is 75.2% in the monoclonal antibody group and 74.7% in the ERIG group. And the mean age of the participants 30.3 years for the monoclonal antibody and the 30.6 years for the ERIG group. And the participants younger than 18 years, 25% in both groups. Major exposure vector is dogs in both groups, more than 93%, and the most exposure were transdermal white, and the mean duration between exposure and the randomization is about 15 hours in both groups. come to adverse events. Total of 85 adverse events, 55 in the monoclonal antibody and 30 in the ERIG group in 66 of the 3,994 participants. The severity of the events was similar in both groups, and the mild events predominated, 44 out of 55 events in the monoclonal antibody and 26 out of 30 in the ERIG group. In detail, among the 2,996 participants in the monoclonal antibody group, around 1.1%, that is 44 from the 55 participants were mild, 0.3% participants were moderate, and 0.1% participants were severe in the monoclonal antibody group. And in ERIG group, total of 998 participants, 1.9% participants were mild, and 0.3% participants were moderate, and 0.1% participant was severe. The mild adverse events reported are the 10 adverse events related to monoclonal antibody, that is injection site pain in 5 participants, pruritus in 2 participants, swelling in 1 participant, hypoxia in 1 participant, and erythema in 1 participant. And 1 event of fever was causally related to the monoclonal antibody plus vaccine regimen. And 14 events were considered causally related to ERIG group, that is pain in 5 participants, erythema in 2, pruritus in 2, swelling in 2, and urticaria in 3. The 2 events, urticaria and arthralgia, were causally related to ERIG plus PVRV post-exposure prophylaxis regimen even after they were negative for the hypersensitivity test in the beginning. Severe adverse events reported, total 8 serious adverse events reported in 8 of 3,994 participants, 7 causally unrelated events, that is in the monoclonal antibody group, 4 COVID-19, 1 cellulitis, 1 myocardial infarction, and 1 road traffic accident. 1 causally related serious adverse event was reported in the ERIG plus PVRV intramuscular group, was hospitalization for urticaria. The event occurred 3 days after receipt of the 3rd dose of vaccine. So all serious events were resolved except 2 unrelated fatalities in the monoclonal antibody, that is myocardial infarction in an elderly person and RTA. Immunogenicity findings, the geometric mean concentration of the rabies virus neutralizing antibody at baseline, that is on the day 0, were similar in both groups. On day 14, the monoclonal antibody titer were increased to 16.05 international unit per ml, and the ERIG group, the titer increased to 13.48 international unit per ml, with the point estimate for of GMC ratio 1:1.19 on day 14. Then on day 65, the titers persisted in monoclonal antibody 3.72, and in ERIG it is 3.70. And the sero response was seen on day 14 in 119 of 121 participants in the rabies monoclonal antibody, and 51 out of 53 participants in the ERIG group, that is 98% in the monoclonal antibody group and 96% in the ERIG group. The sero response rates at day 365 were 98% in the monoclonal antibody group and 98% in the ERIG group. That means this monoclonal antibody is not inferior to ERIG. In the efficacy and outcomes, no participants were developed rabies during the first 1 year follow-up in any group, and the regimen with rabies monoclonal antibody with PVRV was safe and highly immunogenic, providing protective efficacy equivalent to ERIG plus purified varicella rabbit vaccine. In discussion, so this was the largest ever phase 4 randomized controlled trial examining post-exposure prophylaxis for the rabies in the category 3 potential exposure patients, which strengthening the evidence base for rabies monoclonal antibody with vaccine regimen. Main findings of this study, both monoclonal antibody and ERIG regimen showed robust safety profiles, with most adverse events being mild and transient. No significant difference in the total adverse event incidence was observed between the groups. No cases of rabies developed during the first year follow-up, and indicating strong protective efficacy for the monoclonal antibody with vaccine regimen. And the immunogenicity outcomes confirm non-inferiority of the monoclonal antibody as compared to ERAG with sustained sero response in both groups up to 1 year. And the study followed the latest WHO 2018 guidelines restricting passive antibody, monoclonal and the immunoglobulin administration to local wound infiltration only, providing new evidence for this global recommendation. Monoclonal antibody regimen eliminated the risk of hypersensitivity with no cases of urticaria observed, in contrast to ERIG, where urticaria occurred even with negative skin test. The use of monoclonal antibody is favorable in the settings with limited access to human rabies immunoglobulin and the challenge linked to the heterologous origin and supply of the ERIG. So the implication for the health policy and practice, it supports WHO recommendation for adopting monoclonal antibody as an alternative to the immunoglobulin in the post-exposure prophylaxis, especially where HRAG availability is constrained. Strength of the study, it's a large sample size to detect the rare adverse events occurring at a frequency of 1 in 1,000 participants and 1 year of follow-up to detect any delayed safety issues and the treatment failure cases. Serological monitoring of the post-exposure prophylaxis response and the use of vaccine by both intramuscular as well as the intradermal routes, because the intradermal route is used more commonly in the government sector, whereas intramuscular route is more common in the private sector. So the data from this study is applicable to both sectors. The limitation of our study, the study couldn't ascertain the rabies status of the vector animal because the most exposures were caused by stray animals, and the study didn't check the immune response after each dose of the vaccine, so which would have provided information about the rabies virus neutralizing antibody kinetics. And as it's an open label study, it could also a limitation in the assessment of the adverse events. So to conclude, monoclonal antibody with the purified varicose rabies vaccine is a safe, immunogenic, and an effective option for the passive component of rabies post-exposure prophylaxis in category 3 potential exposure cases, it reinforcing its role in the WHO essential medicine list and the health guidelines. Thank you.
Okay, can we have the analysis also now? Hello? Lasima, can you proceed with the... Yeah.
Here, the study analysis. The study is a randomized control trial.
Can't hear you well, Lasima. We have to talk loudly.
Randomized control trial is one of the most powerful, most reliable tool for clinical research, in which participants are randomly allocated in 2 or more groups receiving the intervention or treatment and other receiving a control, and it is a gold standard for the efficacy and safety of drugs in medical interventions.
Go ahead, what's happening?
Sir. So, just a second, sir.
Slide is not changing or not? Hello?
Hello, sir.
What's happening? We can't hear you.
Sir,
There's a problem. Ashwati, can you continue the presentation then?
Sir, can you hear me, sir?
What's it?
Sir, can I... now audible, sir?
You're audible. Be a little more louder because come here and then change the slide. We are not able. Go ahead.
Yes, sir. Sir,
Yeah.
the study analysis based on the CONSORT checklist. CONSORT is a consolidated standards of reporting trials were created to ensure high quality presentation of the conducted RCT. This guideline consists of 25 checklist items that the author needs to fulfill before submitting the manuscript to a journal. This is the consent checklist. According to this, we are analyzing the study. And the study title and abstract, it is the title and abstract is clearly defined. The post-exposure prophylaxis regimen of rabies monoclonal antibody and vaccine category 3 potential exposure patients. It's a phase 4 open label randomized active control trial. So the structured abstract includes background, methods, finding and interpretation. So it's clear and complete, and its identification as a randomized trial in the title, and it is structured summary of trial design, method, results and conclusions are included. Next is the introduction, scientific background and rationale. Strong rationale and relevant context are explained, which is consists of detailed on rabies burden, issues with both ERIG and human rabies immunoglobulin, and rationale of monoclonal antibody. And it also gives the specific objective or hypothesis of the study. Aim was to evaluate long-term safety of immunogenicity and efficacy of immunoglobulin and rabies immunoglobulin and ERIG plus vaccine. The method is, the description of design is described. It's a phase 4 open label randomized active control parallel group 3:1 allocation. And but the important changes to methods after trial, it's not mentioned, it could have specified. For this participant, eligibility criteria of the participant is clearly defined, which included more than or equal to 2 years with WHO category 3 exposure within 72 hours, and excluded prior rabies vaccination and allergies. Setting and locations of data collection is included, which conduct that is the 15 tertiary hospital across India. Interventions, detailed description of interventions for each group as described. Outcomes, define primary and secondary outcomes, including how and when they reassess, which is complete. Primary, treatment related serious adverse events, and secondary, including serious adverse events and adverse events, survival and GMCs and zero responses are also included. Any changes to outcome after the trial start, which point is not specified. Sample size, how sample size were determined is statistically justified, that is the participants received immunoglobulins and probability to detect more than or equal to 1 serious adverse events if frequency is 1 in 1000 and 3:1 ratio, and there was no explanation of any interim analysis and stopping guidelines. Randomization method used to generate random allocation sequence and permutated block design, block size 8 using SAS 9.4 version, and it is clear. The allocation concealment, the mechanism to implement random allocation, it is central randomization via interactive web response system, that is SAS version 9.4. So it is adequate and concealment is present. The implementation, the who generated the sequence, enrolled and assigned, generated by unmasked statistician, site staff enrolled and assigned via web system. Next is blind team. The open label, only lab personnel were blinded, so it is appropriate for phase 4 safety design, but potential bias noted. Statistical methods, it's detailed in sufficient. Statistical methods for primary and secondary outcomes, GMC via long transformation, chi-square Fisher for proportion, t-test for comparisons are used. Method for additional analysis such as subgroup analysis and adjusted analysis, it's not mentioned here. Results, for each group, the numbers of participants who were randomly assigned received intended and treatment and were analyzed for the primary outcome. But the flow diagram, participants through each stage, figure included, and for the each subgroup, losses and exclusion of after randomization together with reasons also added. In the results, recruitment, dates defining recruitment and follow-up, which is included, which is August 21, 2019, March 31, 2022. Last follow-up is April 25, 2023. It is fully stated. The baseline data, the table showing baseline demographic and clinical characteristic table is included with the 8 sex weight comorbidities, which is appropriate. The numbers analyzed, numbers included in each analysis clearly given for intention to treat and safety per protocol and modified per protocol set, and it is transparent. Outcomes and estimation, results for each primary or secondary outcome, effect size and precisions are described, like serious adverse events, GMC, zero response rate with the confidence interval is reported. Ancillary analysis, that is subgroup or adjusted analysis, intramuscular or IED route comparisons reported. Harm, all important harms are reported, adverse events and serious adverse event, casualty, severity and outcomes detailed in tables. The limitation of the study, that is source of potential bias imprecisions, discussed as open label design, so inability to confirm rabid animal status was included. And also the immune, they could also didn't check the immune response after each vaccination and or immunoglobulin administration. Interpretation, consistent with results, balancing benefits and harms and considering other relevant evidence. So here it is balanced because acknowledges limitation and support the WHO guideline. So interpretation was appropriate. The registration, trial registry and number as clearly mentioned. Protocol mentioned funding, source of funding and role of funder, that is Serum Institute of India, detailed role disclosed. Overall concert compliance rating, high compliance, major strength, clear RCT design, sample size justification and transparent result, excellent reporting of safety outcomes and immunogenicity, concert flow diagram included and detail, registration and funding disclosure present. The minor gaps are no explicit statement on protocol changes or outcome modification. Open label design may introduce bias and sponsor involvement could influence interpretation, though transparency is noted. Summary, this trial on rabies monoclonal antibody demonstrates strong adherence to CONCEPT 2010 standards with robust methodology, clear reporting and high external validity, and it provides credible evidence that immunoglobulin and vaccine is safe, immunogenic and effective for category 3 exposure, supporting the WHO's 2018 recommendations. Thank you, sir.
Okay, it's over. Anju, you're there? I think now we will go into the comments. Dr. Ramankutty, you want to say something?
Actually, there is not much to say. I think the presentations have been very good. From the design perspective, it is all very clearly laid out. So, how it's possible. The point is about the policy issues we have already discussed. The terms, I thought maybe people may have a doubt. One is geometric mean. Geometric mean is used when you are comparing ratios. So geometric mean is like the nth root of the product. Like suppose you have 5 observations, you multiply all of them and you take the nth root. Nth root means raising to the power 1 by 5, which of course with computers it is easy, it's not too difficult. So that is the one recommended for ratios. That is geometric mean, about geometric mean. And of course the design is well discussed, and the phase 4 you all know. Phase 4 is used when already you know, I mean, what is efficacious. Not for testing efficacy, but it's for testing what happens after the drug is given, etc. So that is exactly what they have done. So that is also very clear. And of course, they have their own reasons for this very complicated design, because it's like a 3:1 randomization and all that, which only shows that you can use various options when you design a study. You need not have a 1:1 randomization. If your question is posed in such a way, you can have different designs possible. So these are some of the things which probably people may have a doubt about. If there are any other questions, I will be happy to answer. Of course, Women's World Cup is going on.
The thing is that only thing I mean, there are today's actually there is 15 participants is good. But one thing which I was a little surprised was in the discussion somewhere. Probably I didn't read this article, some other article. They talked about the epitopes, and that is what is raised by the Indians, that it may not cover epitopes. They had very categorically written in the discussion that the epitopes covered by the monoclonal antibody covers all the epitopes which are available in India, South India,
Correct.
most of the, except in American countries, some sea snakes. Therefore, we are fully justified. That statement did not come. I was looking into the article, but maybe it is a different article which gives that. Few things which I would like to say. I don't know why they excluded children below 2 years. You know, one thing which worries us is that there's a lot of failures in the original study done in was done in Thailand. You know, that where it's done, there has been failures, but not to this extent. And we can understand there was no failure in this. You know, they didn't look at the efficacy of the vaccine; they looked at the side effect. And side effect, monoclonal antibodies are definitely superior because you know that. And the other one is an equine rabies antiserum, which is given. If you look at the cost, equine is somewhere near 2,000 rupees. Human rabies immunoglobulin is somewhere near 4,000 rupees. And the monoclonal antibody comes in between 3,000 rupees per vial. Now, a few things here you have to notice. There was no failures because they didn't take up patients who were more than 3 days old if the bite was anywhere in the body. And in the face, if the bite was more than 24 hours, they didn't pick it up for the intervention. But that is not what is practical. You know, in practice, patients may come after 7 days or 10 days, you still have to use it. Therefore, they should have compared it all, given the statistics for all of them. And another thing, they did the skin test. Now, they excluded patients who were allergic, but actually before 2018, the WHO advised skin test. After 2018, they are not advising the skin test for equine rabies immunoglobulin, but the pack which comes with that advises skin test. So, these are all legal issues, you know. And I understand that last time when I met a doctor in a conference, they said that they do the skin test. And 8 out of 10, that's what one doctor told me, there'll be an allergic reaction. See, the biggest advantage of monoclonal antibody is it is not having any blood product. Allergic reactions are very less. One thing to the other, the potency will not change. While equine and human antiserum, you inject a person, take the antibody, it may not be equivalent from one vial to the other. It need not be. That's what they say. Therefore, I thought human rabies immunoglobulin had an advantage. They didn't talk about advantage. They just said it is equivalent. That is allergic reactions. They say 8 out of 10. And they have, last time when I went to a meeting, the general hospital, they said some patients, they had to give it only in the ICU or in the, because of the allergic reaction. The national guidelines, what it says is, this has to be given anyway. Some patients may develop anaphylaxis even if the skin test is negative. Therefore, you must know to treat anaphylaxis, don't do the skin test. But even then, everybody is doing the skin test. That's it. Well, anything more anybody wants to say? Dr. Kalpana, any questions? Dr. Anju is not there, therefore, a lot of questions are not there, I think. Anju Kanmani, you are there or not? God. Kalpana, you are there? You want to say something?
Sir, the antibody test was done for a very small number of patients, maybe because of logistic reasons. Only 100 or 200.
Yeah, maybe that is where I may have had reduction, but it has been done in more. Can't hear. What's
The number is small, some 100 or something. The antibody testing is like.
See, the most important thing is I would have expected it to look at the efficacy. They looked at the side effect.
Adverse events.
They looked at the adverse events. That's not what we are concerned more. We look more at the efficacy. But efficacy 100%.
It's 90. No one developed the 98% in both.
Did anybody develop? I don't think anybody developed rabies. But they safely excluded children below 2 years. Why? I don't understand. They excluded children face bite more than 24 hours. They excluded. That's not a pardonable. That is there. And then we like to look at the generalized bite. They excluded patients who were more than 3 days old. Therefore, they had 100% results. That is not what is field situation. That's the only thing I would like to say. Anything more, Dr. Ramankutty, you would like to say something? Anju, you want to say something? Anju Deepak?
No, I have nothing more to add. If anybody
Yeah.
has a doubt or something, I can try to answer. That's all.
Okay. Now, may I ask you one question, Ramankutty? This is a very important study, no doubt. Many patients are dying. People would like to know where to give and everything. Who has funded it? Serum Institute. Will not ICMR fund any of these things?
Yeah, they should. I mean, I don't know why they don't, because they are the ones who should set the policy. Like they should look
Yeah,
at.
this is a very important study. They should have funded it. Therefore, we would have believed it more. Here, the company which is manufacturing is funding it. Therefore, that.
And I don't know. Probably you are aware. There is another agency now in India that's called HTAIN, Health Technology Assessment India. You have a website and all. And in fact, Sri Chitra was part of the. I mean, they have a network of institutions. They are looking into this specific question, like for each intervention, is it cost effective? Is it the right thing to do? Because what they say is if the HTA approves, then you can include it in Ayushman Bharat. If it is not approved, it is left to the person's own, they can fund it themselves. So that is a general thinking. So probably it might be something that they can take up. Maybe you can write a letter, the IAP can write a letter and ask them to do an HTA on this or something. I don't know.
Yeah, but you see, last time when we said, we asked, one of the main problems in rabies vaccination is that there is complete, every failure, it comes up in the papers, everything discussed.
Correct.
But even in the initial study done in, if you look, I looked at the whole history. There has been failures. People who have been given immunoglobulin. See, in the WHO conducted the study in Thailand, direct supervision WHO with their consultants. Even then, there were 1 or 2 failures. Not like this 14, 15 failures in 1 year. But
yeah, that is true. I mean, that is right. That is exactly the point that because of the media attention, even one thing gets blown up, and then what finally happens is a lot of people suffer actually because no proper study can be done in the light. I mean, the media limelight, it becomes very difficult to conduct a proper study.
And I don't know when this is going to burst out. See, a person who is giving monoclonal antibody, I understood from the last meeting I attended, not a single case of rabies has come out in the patients who have been given monoclonal antibody. The reason, of course, is the number of patients who are given treated for rabies in the government sector may be 100 times more than in the private sector. And even today in my hospital, I understand that the doctor tells the patient, look, free treatment is available in the government sector. If you want it here only, we will give, because that's the right way to go about it. Later on, they will accuse, and the treatment is totally different. I don't know when it is going to come into public domain. That
yeah, it may blow up at one point of time. Correct. One failure is enough to make it controversial.
Yeah, nobody knows about it. Nobody talks about it. See, we are giving monoclonal antibody, which is not even mentioned in the national guidelines. In fact, in one of the books, community medicine doctor has written, and not only that, see, national guidelines gives 5 doses of rabies, 0, 3, 7, 14, 21, 28, I think. While WHO gives only 4 doses rabies vaccine. There's a difference. And one community medicine professor has written, all doctors who are not following the national guidelines, now the WHO has brought it down and everything, can have legal problems. You understand? The poor practitioner who practices can be in trouble later on, because in a court you can be thrown the national guidelines and say, have you read it? And what right you have to not follow it. But then, of course, the ACVIP is a 40,000 or 50,000 pediatricians. They are very clear on. Therefore, there is a problem in this. I don't know whether which way, but surprisingly, this does not look for the superiority of the monoclonal antibody. This looks for equivalence. I think the Serum Institute just wanted to say it is equally effective. That's all.
Yeah, that's right.
So if there is anything else, Anju Deepak, you want to talk? You are there.
Yes, sir, it's okay. The presentation was very good. As you
Yeah.
said, for practicing pediatricians, yes. Another thing is that this is a study done by Serum Institute. As you said, how much can we go forward with that? We also, now OPD always recommend them to visit the government hospital first and then decide on whether they want to do that. But in our hospital, we have been giving this for the past 3-4 years. And I don't think that even one case of positive rabies we had after that.
We are giving monoclonal antibody in a
Yes,
hospital.
yes. For the past 3-4 years, we are using, sir.
Yeah. The question is, when you are having your relative or on your own friend, he calls up and says, doctor, should I be giving the monoclonal antibody, go to a private hospital, or be giving the equine antiserum? What will be your answer?
We always ask them to take a second opinion from a government hospital, sir, to be on the safer side legally. We do tell them that we have monoclonal antibody and this is the problem. But many of them agree and say that we will continue treatment here. So that's how we give.
Okay.
So that the legal issue is there. But we do discuss with them, but we don't record it anywhere. I don't know how much we are safe legally in doing that. But we always tell them to get a second opinion from the rabies cell of the government hospital.
Now I'll tell you what I tell. Some people call me and ask, what should I do? Then I tell them that it is better to, see, by all reasons, monoclonal antibody is superior because it doesn't contain any blood product. Product to product variation is not there. Anaphylaxis is not there. And it is internationally accepted by WHO. And ACVP recommends it over immunoglobulin. Remember that. It recommends it over that. Now, another thing is, which I often, Dr. Ramankutty, which comes about is, which nobody discusses it, many people are having pet dogs.
Yeah.
Pet dogs are completely immunized. Nowadays, veterinary doctors immunize it. Now, if you have and nowadays in the young children, even in WhatsApp, you see they put their fingers inside the cat, they rub it on their face, the saliva goes inside. Saliva itself going in the mouth is a grade 1 category. Now, if any bite anywhere in the mouth, anywhere in the face becomes grade 3. Now, if it is a completely immunized pet dog, okay, complete immunized means he should be more than 1 year. He should have taken the first 2 doses 3 months and then the booster dose at 1 year. If a dog is below 1 year age, bites means it is not immunized. Then you need not give the rabies prophylaxis as per international guidelines. Anju, what do you think will we be doing if there's a pet dog bite?
Even if the pet dog is vaccinated, sir, we recommend for the full vaccination of rabies. So,
is it for our own purpose?
because sir, there has been cases where rabies has been reported, no? So we don't want to take any kind of.
Is that the only reason? Is that the only? Yeah. I had a real problem. One person in our flats, he rang up and called me and said that it's completely immunized. When she just wanted comfort. And I unfortunately told her you have to take it. And I get a call from the veterinary doctor next. Why do you advise like that? Why do you think we are giving the vaccine? But Anju, you must know one thing. The national guidelines gives in black and white. Even if the dog is completely immunized, if a pet dog bite, you have to immunize the children. You have to give rabies.
Okay.
It's given in black and white in the national guidelines. Many pediatricians wouldn't know it. And the national guidelines given by the Ministry of Health says that they cannot guarantee the purity of the vaccines given to veterinary science. When they have written in black and white, and you don't give it. Therefore, I told the veterinary doctor, please don't get angry with me. It's the Indian is the Indian government which has written like that. Therefore, I have to follow I will follow the national guide. There's no question.
Okay, sir.
Because people ask you because they want comfort. Because when you have a pet, invariably you will get a scratch or somewhere or here again and again. And luckily, but so far there has been no rabies from pet dogs immunized. I never heard it.
Okay. Okay, sir.
Dr. Shija is there, I think. Dr. Shija is there?
Yes, sir, I'm there. I would like to add something. So there is a paper by Dr. Aparna on the rabies prevalence in vaccinated patients. So the rabies vaccine efficacy in dogs done in a Trivandrum itself, it's only 70%. So we definitely, for pet dogs vaccinated, we have to advise vaccine. It is not the same efficacy as adults. It's only 70% efficacy in case of dogs.
Which one you mean? I didn't understand. Efficacy for what?
Anti-rabies vaccination.
In the dogs.
The antibody titers of dogs who had received the vaccine was checked. Only 70% seroconverted. So with that statistics, we absolutely cannot say that you have a pet dog, you don't have to take a vaccine. Because the vaccine cold storage is pathetic. Many of the families, they give vaccine to the dog by the veterinary doctor coming to the home and giving the vaccine. What do we say about the cold chain for such a vaccine? So 70% efficacy, that is a documented published paper in the ICMR journal. So with that, definitely we have to give vaccine.
Recently, doctor? Published recently?
Not recently, it has been there for quite some time, sir. It's not very recent. I think must be 4-5 years old.
These are very important points because somebody will say don't vaccinate and it develops rabies, you had it. You know, this is a life and death issue actually. And
yes, sir.
And this, I mean, what do you think about this article?
So no, article wise, yeah.
This journal article, you were there from the beginning, I suppose. Dr. Shija, you can hear me? I think I can't hear.
But we have a problem there because this is a product which is not approved in any of the developed countries. You are using a product that is there in many developing countries. Serum Institute is supplying it to a lot of countries, but there are neither the US, UK, none of them are using our immunoglobulin. So if our monoclonal antibody was so good, they should have used it, right? Our problem is it's a action against a single epitope. So that is something that I'm always concerned about. So it is not effective for bat rabies. It is not effective for zoonotic rabies. And in Kerala also, it's not all dog rabies. 90%, 99% is dog rabies. But the vaccination failure has happened in many wildlife encounters. So that is also a problem there. We need a little more studies and little more.
But what about the Cadila product? Cadila product has 2 epitopes.
Yes, but that is murine. That's not like if any day a monoclonal antibody against a human monoclonal antibody would be superior to a murine monoclonal antibody.
Now, what I want to say,
sir, our the rabies guideline, national guideline, was published after 2018 WHO guidelines. So it is, they have gone through the WHO guidelines, but still they said that we need a Indian study, and they do mention about the monoclonal antibodies in the fag end of that guideline. Towards the end, they have written that, but they don't have, because Indian studies are not there, they are not recommending. But now with this study coming up, probably the next guideline, we may have a recommendation for monoclonal antibodies. And another problem, we need to know that for all the vaccination failures that have happened, the moment the central team comes, the one question they ask invariably is whether you have given monoclonal antibody or not. It's a real headache because whoever comes for an inspection, whatever they know or what is the science behind all that is immaterial. What they jot down becomes important. So this is a question they keep on asking first. But thankfully, all the vaccine failures have not been with monoclonal antibody. In fact, we don't have any with monoclonal antibody.
Actually, I don't know whether these people presenters missed it. I was going through the article carefully. Whether this article or a different article, I will send it to you. They have clearly written that it covers all the epitopes available in India. And the only thing which it doesn't cover is epitopes which are few sea snakes in America. That's clearly written somewhere. I forgot, I didn't read what it is. And number one, Dr. Shrija, is when they say that it doesn't cover all the epitopes, then they should have told in the national guidelines that we are not recommending what is given in WHO for the following reasons and the following.
No, sir. No, sir. It is not like that. The reason is this is a single epitope monoclonal antibody. There's no doubt about it. It's a single epitope monoclonal antibody. But that particular epitope is preserved as far as rabies virus in India is considered. So there is no concern for Indian population for this monoclonal antibody because no mutation in that particular site has been reported from Indian studies. So, sir, you're absolutely right to say that in India, we don't have to worry at all. But for example, Africa, this particular epitope is mutated in 60% of the stray dogs in Africa. So this is an epitope that has a potential to mutate. But thankfully from India, no case has been reported. No, because like the Paload Center, they do genotyping also. So from the genotyping study also, they have not found any mutations in this particular epitope for which we have the monoclonal antibody. So right now, of course, that is a good option for us.
Shrija, I find it very funny that you allow the monoclonal antibody to be marketed, to be given to the in the hospital. The government fully is aware that it is being given in private sector in a very big way. And if it is really doesn't cover, if they feel. And another thing is the bat bite. National guidelines clear. Bat bites in India don't require they don't require rabies vaccination. They have written in black and white in the national guidelines, if I am not mistaken. But that's what I remember. Therefore, there are so many things in rabies which are life and death issue. I hope that none of our pediatricians get into trouble. To them, I will say, please give as far as possible the even for pet dogs, give them the immunization. That's what I advise. If you are giving monoclonal antibody, inform the patient that this is not what is given in the national guidelines, and this is what is given private sector. If you want to go into the government sector, you please go ahead. And one thing which I found was here the allergic reactions are almost equivalent. But I don't know whether when I came to the SAT hospital, the community medicine doctor said 8 out of 10, they get skin test is positive. Am I right, Dr. Shrija?
So that particular thing about this allergic reaction is again brand dependent. Because right now the ERIG that was given, it is from WinLab or something, that's highly reactogenic, 80%. But the same like ERIG, it has happened multiple times nowadays because patient cannot afford monoclonal antibody. Patient HRIG is no more available. So when ERIG, this brand is reacting, they have given the same person in ERIG from another brand and it has not reacted. So it's a brand problem. So the current brand which is available in the government sector is highly reactogenic.
See, that is a problem. We now know that it is brand to brand allergy is there. Difference is there. How do you know the potency? There's one of the problem of ERIG is the potency you cannot guarantee. While monoclonal antibody, you can guarantee. There's not a blood product. It doesn't require skin test. Regarding skin test, the national guidelines says don't do skin test. WHO after 2018 says don't do skin test, but nobody dares not doing a skin test. Because they say even if the skin test is positive, what you're going to do? You have to give the vaccine, isn't it? You have to give the immunoglobulin. Am I right?
Yes, sir. And sir, as it is the other way around also. Skin test positivity or skin test negativity does not ensure that you are not going to get a reaction subsequently.
Yeah.
Even when the skin test is negative, you can still have an anaphylaxis subsequently.
That's why
but the chance of getting an anaphylaxis is more when the skin test is positive. But ASV, we don't see, no, even though we know that it causes anaphylaxis, we give without a skin test. But ERIG, because the package insert, because ultimately it says that if the package insert mentions something, then we need to follow. That is what they say. So that is the reason why it is being followed. Personally, I am against it because anyway you will give and anyway you will manage.
Now, final one more question, Shrija. Where this in the government sector, is it given at any time by any doctor or only in a specific clinic by a specific group of pediatricians, perhaps group of nurses? Because
No,
the intradermal injections.
So usually it's always in the preventive clinic. So like, for example, medical college, it is always under the community medicine. So it's always there only. But when it comes to taluk hospitals and this thing, it will be given by whoever is on duty. The sisters don't give. I find that is wrong because sisters would be much better at giving this thing in a particular route compared to a fresh graduate. But that is the fact. That is a fact.
Because giving intradermal, even the intradermal vaccine is not an easy thing in children. Sometimes it goes subcutaneous, it has no effect there. That's what one of the main reasons why I was talking to somebody is that probably it is being given subcutaneously. Yeah. Okay, we had a long discussion. Thank you, Shija, because she's one of the most important speakers in most of the IAP. I didn't realize I was looking for you and you never came up with any opinion. Anyway, I looked good. I picked you up. Anything more, or shall we close the meeting? Ramankutty, you want to conclude? I think he has gone. I think Ramankutty has also gone in. Okay, then Dr. Srijit is there.
Yes, sir. I'm there. Hello.
Yeah. And I
Hello,
think
can you
now
hear me?
Kanmani has also come, I think. Anju, you have come? I can see the name AKK. Anyway, Srijit, if you want, you can conclude it.
Okay, so thank you, sir. Thank you, sir, for the excellent discussion. So I said we have a very good academic discussion on post-exposure prophylaxis on rabies. So I must thank the PRS team, Dr. Amritha, Dr. Aswathi, and Dr. Noor for the excellent presentation. And I also thank Patanaban sir for coordinating and Ramankutty sir for the expert comments. And also we have valuable inputs from Dr. Shrija madam and all. And thank you for joining for IAP Today's Journal Club.
1 minute, Srijit, before we sign off. Dr. Amritha, you want to say something? You are there? Because she's the mentor. She's the person who mentored these two people. I think she's not in the state. Anyway, the icing on the cake was Dr. Shija was also there. Therefore, she gave very, very practical points, which I never knew. Okay, thank you very much. Shall we close?
Yes, sir. Yes, sir. So thank you for joining. Thank you, Shrija madam and all. And see you the next time of Journal Club. Oh, good night. Good night from IAP. Toronto. Okay.